Well, thank you, everybody, again. Hopefully, I'm not going to be too boring for you since some of this is a little bit over what we did before. My name is Jonda Clemings, and I am a person with lived experience. I am struggling every day with depression and PTSD, and I'm going to talk to you today about my journey, both professionally and personally, in voluntary and involuntary treatment. I have had major depressive disorder for about 20 years now, and I got the PTSD probably about 13 years ago. I have had individual and group therapy, psychiatric management, intensive outpatient mental health programs. I've been in both state and private hospitalizations, and I've also had ECT. On my professional side, I am a licensed social worker, and I have my master's in social agency counseling, and I'm currently working for the Central Ohio Area Agency on Aging in Columbus as a case manager for the Passport program. Just looking around the room and knowing the population and stuff that's here, there are probably many of you that could get up and present this part of the presentation for today. You have had your own lived experiences. You've seen the sides of things when it's voluntary and involuntary treatment for you. So please just accept some of what I'm sharing today as part of your story as well. Next slide, please. As I mentioned, I'm a licensed social worker, and in my bio, it talked about I've worked in private psychiatric hospitals, I've done nursing homes, home health care, hospice, community behavioral health. I was a training and technical assistance provider for a statewide organization. I've done case management at a couple places for persons with HIV and people with disabilities. So I've been around the block in the last 30 years throughout my field. I have said, for the most part, I think I chose the right discipline to go into when I chose social work. It's very empowering to me to be able to help individuals and stuff on their daily struggles and hopefully be able to relieve some of what they're dealing with my assistance and through my guidance for them towards dealing with what they're going through at this time or any other time. As I mentioned, I'm going to share some of the things that I've seen professionally, some of the things that I've had happen to me privately and personally. And hopefully it all makes sense and stuff in the end. If you could move the slide forward, please. As far,
I think she's one ahead of you.
If you could go to the slide that says guardianships and commitment. Thank you. As a professional social worker, I have had the opportunity and sometimes dismay in making the decisions for people whether or not they should be pink slipped and involuntarily committed to a psychiatric hospital or for services. Unfortunately, our system is not perfect. We do not have the types of services and programs available that helps guardians to be the best advocates for their individuals. We can see that if you pink slip somebody, you're taking away all of their abilities to make their decisions for themselves around their treatment stuff at that time. You're seeing people that have had to be detained physically, emotionally, chemically, so that they get the treatment that someone else says that they need. We often see that family members get into fights over who can be the guardian and who's not going to be the guardian, purely just based on who's going to be in charge of the estate and not thinking about the person that's involved here. We've got issues as far as looking at people being involuntarily committed that may not have happened if they would have had somebody who really worked with them to try to negotiate what was going on with their situation and try to find out if they can get voluntarily treated either in an outpatient or inpatient setting. What we're trying to figure out and stuff here often when we're dealing with guardianships is how to ensure the needs of that individual and the community around them. So we wanted to be able to try to figure out how we can get resources for them so that they don't have to go through having a guardianship. Part of this is pre-planning. If you do not have your advanced directives right now for your psychiatric advanced directives that tell who you want to make decisions for you, what hospitals that you want to go to, what kind of treatments that you are willing to have, what treatments you're not willing to have. If you don't have that right now, I really encourage you to go out and start one of those and have that available to be able to tell professionals what you're interested in as far as your own services so that that goes on. Unfortunately, many communities do not have what it takes to be a good guardian. There's little process as far as having somebody evaluated to become a guardian. You got to do things like do a one-page sort of psychosocial assessment on them to see if they need it. That can be completed by a social worker, a doctor, a counselor. We do not have individuals in guardianship positions that are receiving training around how they should be providing their guardianship services. We don't have information about how those individuals are being monitored to make sure that they're making sure that others are being taken care of in the best possible ways. So between pink slipping people and getting them into involuntary commitments and guardianships, we really need to take a step back and see how these processes are going. Next slide, please. So it's time for me to talk about how I got here as far as my diagnosis. I ended up having a lot of health problems about 20 years ago. Ended up in the hospital, medical hospital, on numerous events. They couldn't figure out what all was wrong with me. Took quite a bit of time to physically figure out what was happening to me. And that whole process really got to me. And I started experiencing what I would call the beginning of my depression time. I was sad. I felt worthless. I felt hopeless. I had a lot of guilty feelings amongst me. There were issues and stuff that I wasn't sure if the emotional was causing the physical concerns, if the physical was causing the emotional concerns. So I sought out to get some treatment. First, initially, I started with individual counseling at a local counseling center. We tried to deal with loss I was dealing with at the time, the insomnia that I was having where I was only sleeping maybe 2 or 3 hours a night. Dealt with where I thought my feelings and stuff were coming from, if there was anything that I needed to process from my younger years, because I was one of those statistics that was outside the boundaries of when I was actually diagnosed with a mental illness for the first time. We dealt with the restless feelings and things that I was having, you name it. When that really wasn't working, I started talking to my family physician about getting on some kind of medication. And he tried, he really did, but he was not a specialist and felt that what I needed was to be seen by a psychiatrist. Now, being a social worker, I've been ingrained that medications are part of the issue. and that they can be also part of the success. And I wasn't quite sure how I felt initially about having to go on medications. I looked at myself and said, okay, you're a social worker, you ought to be able to fix yourself. So there was some of those feelings going on that kept me from wanting to take medications at first and really wanting to work around how I could be treated in other areas. But the other things really weren't helping. So I started on medications. At first and stuff, it was my choice. I wanted to go on something that could help. I will tell you, I've been pretty good as far as the side effects on medications. Had a little bit of weight gained from a couple of them. But that was probably the worst part of it. I'm not sure, truthfully, if the medications have worked or not. Right now, I'm on 5 different medications, 2 antidepressants and 3 antipsychotic medications that act as mood stabilizers. The difference in me sometimes is very questionable, how I am on my meds, how I am when I'm not on my medications. If you could advance to the next slide, please. I'm not sure, as I mentioned, if I'm getting better or not. I still struggle each day with having crying jolts. I still struggle each day with feeling isolated, feeling that I'm not good enough for anybody, feeling that I'm not good enough for myself, that I'm not doing my job as well as I could, that I'm not being as friendly as I could with my coworkers or other people that are in my lives. I do know that when I'm not on the medications, I'm extremely suicidal. And that was the cause for the 3 hospitalizations and stuff that I had. 2 to private hospitals and 1 to the state psychiatric hospital. Next slide, please. As I mentioned, I did some work at community mental health and in the homeless population. I saw a lot of individuals who have serious mental illness and are living with everything that has to deal with. I saw people at the lowest of the low days that they could have, when nothing seemed to be going right and they were harming themselves or talking about harming somebody else. So we had to look at doing inpatient placements. And having the experience I've had as on a professional level and private level, those sort of intertwine at times. And so I always want to think, how would I want to be treated if I was the one in this situation? So I saw people go in and out of group homes, assisted living facilities, the community, tried to do everything as best I could to make sure that people stayed in the least restrictive environment. I was thinking about one of Rob's thoughts this morning about the helpline calls. And personally, I've never used one. And my sort of reason being is because of what things Rob said. I'm suicidal. If I say that I'm suicidal, who's going to come knocking on my door? What kind of things is that going to happen to me if I get the label suicidal? Who is going to place me someplace, probably against my will? What is that going to be like? Is that trauma better than not? So I've tried to stay away from the call lines. I also have difficulties in individual counseling and group counseling with sharing some of my thoughts, because if I'm not with somebody who is had that same walk that I've had, they don't understand. The professionals and stuff, and as much as I can say I am a professional, don't always agree with things that I want to see happen to me, and they don't always understand what's going on. So next slide, please. As I mentioned, I've been on a lot of different medications. It helps me, as I've said, to decrease some of the symptoms I have. I once went on a drug holiday before I was hospitalized to see if the medications really were or weren't doing anything for me. That was pure hell, to be honest with you. The suicide thoughts that I had, and the racing thoughts, and not knowing whether or not I was worth taking an interest in myself or not, was horrible. I saw my dad, basically, I found him in an unconscious state. He had stroked out at home, and I'm the one that found him. That's what led to my PTSD and trying to deal with that kind of loss and situations and stuff that were going on with that. That was probably some of the lowest lows that I've had. I do believe that the medications help me, but there's still always that thought behind my head that says, does it really? Next, please.
She's one ahead of you again.
Okay.
Stay there. Just stay there, yeah.
Okay. I'm going to talk a little bit about my hospitalizations. As I mentioned, I had 2 hospitalizations at private hospitals. It was the same hospital. And I had 1 trip to the state psychiatric hospital down in Appalachia. I was suicidal at the time of each one of the hospitalizations. I was stripped, searched to make sure that I didn't have anything on me, to make sure that I wasn't bringing anything in with me to harm myself, including an oral cavity search and vaginal search and rectal search. I was patted down to make sure that I wasn't hiding anything anyplace else, which Lord knows I don't know where that would have been by that point. I saw myself get basically told I couldn't have my clothes anymore because I needed to be in a gown to make sure they knew what I had on me at all times. So luckily, they let me have 2 hospital gowns, or things would have been really terrible to see out of me. I had to sleep on a pad on the floor. No blankets, no sheets, no nothing. No pillow even. I had slip-on shoes, or they would have taken those away, because if you had the tie-up shoes, you know, they take the ties out. But luckily, I just had slip-ons that I took with me that time. I saw people get treated a lot worse than what I had it. I saw people get told, just get over it. The comment that the person made stuff this morning about just get over it was told. Not always the nicest place to be. On my second hospitalization, at a private institution. They got to the point they said, there's nothing more we can do with you. You're not getting any better. I was there for about 3 weeks, which is quite a bit longer than normal. And they still couldn't help me. So they said, we got to transfer you to one of the state psychiatric hospitals. I was willing to sign voluntarily over that I would be switched to one hospital to another, but they said since they had to transport me that I had to go involuntarily, which led up to all the court hearings and everything so that they could keep me in the hospital. While I was there, I befriended a couple of individuals. One gentleman was dealing with bipolar, and he also caused a lot of harm to himself. The hospital staff had taken him and basically had him on 24-hour supervision, have to be within touching basis so that they could make sure he wasn't going to do anything to harm himself. They finally got him to, I don't know, I think like 5 days that he hadn't tried anything. So they thought they'd take down that. Well, he was struggling with it. And so we were talking about it. Well, I got told that I shouldn't do that. You're not a professional social worker and stuff here. He is not your client. You cannot talk to him any longer. Not that you can't talk to him about that, but you can't talk to him about anything any longer. And if you do, we're going to move you to a different unit. So he asked me what was wrong after I got done with my team meeting. And it went by that he decided he'd show them, so he harmed himself. So then I felt the guilt related to that. Well, shouldn't I have told him that? Shouldn't I have did what I do, make him do that? You name it. I also finally got to the point and stuff after that hospitalization of being in there about 4 months for inpatient at the state psychiatric hospital, got to feeling where I did want to kill myself. And that was basically my goal, to feel better and not want to kill myself. So they released me from the hospital. I had to go into intensive outpatient treatment so that they could monitor me. I wasn't allowed to live by myself for so long. I had to live with somebody else. Luckily, I had a wonderful friend and her husband that took me in, and they said that they would take care of me for a couple of weeks so that I could prove that I could stay outside on my own. She also helped me get through ECT. That was sort of the next step, trying to get work through. If I'm able to get through ECT, hopefully that will help. I always keep hoping out there that there's going to be something that's going to do better for me, something that's going to help me. Currently, if you want to advance to the next slide, currently I'm looking at a couple things, a stent ganglion block that's supposed to help with PTSD. I'm taking an interest in transcranial magnetic stimulation, sort of similar to ECT, but not. There's a medication they wanted me to try that's an injectable that was sort of discussed and stuff earlier this morning. Unfortunately, my insurance won't pay for it. But I keep hoping that there's going to be something that's going to be out there that's going to make my life better, make me want to live, make me want to be your friend, make me want to feel like I think I should. Some of that has played cost on me. ECD did leave me with some amnesia. I lost a few months in there, well, not to the extreme that was discussed as far as total amnesia, but I lost a few months of my life from that I can't remember. I have the devastation of how I was treated, how I saw people being treated. I knew that there was something better out there. And I tried to fight along the way to be my own advocate and to be the advocate of other people. So on that wonderful cheery note, I'm going to turn it over to Rob.
I didn't know if we wanted to take some questions now before
Good.
I
Good, yeah.
start. Yeah, just plow through. Well, thank you for that powerful story, and and for sharing that. And it does relate into what I'm talking about, because I mean, through your story, I was struck by, at first it seemed, there was real agency, your desire, you're seeking, help and assistance. And then it became blurrier and blurrier. And then clearly there were situations where you really didn't want what was happening to you. And that sort of movement back and forth, where at any time, depending on where you were and who you were interacting with, we didn't know ourselves, and you didn't seem to know either. They didn't seem to know even like how much control you had in that situation. Is that, yeah. And that's sort of what I'm talking about now too, is like, I think this is common, unfortunately, that you're not alone in that kind of experiences, and that this sort of defines what I'm calling for today, coercion in the community, where people are kind of moving between different institutions, different situations, in and out, and between voluntary, involuntary, or situations that you're not even sure which is which, or they're overlapping. And I'm trying to just take a quick look at sort of what we know and don't know in terms of some data and information and studies in that area around how this plays out, and how it might be relevant to understanding, I guess, where we're at systemically. So one of them is right off the bat, something that's highlighted in Jonda's story a lot, that many voluntary help-seeking patients can be either advised to comply with the rules or else under some sort of threat, or they can be literally made involuntarily at the drop of a hat. So it didn't matter that all along. It sounds like you've known that you're having struggles and clearly had insight into your situation, and nope, that can just as easily be used against you. Like, well, you're clearly mentally ill, you even know it yourself, kind of thing, and they use that against you. And so we see that a lot. And in fact, here's an example from the Texas Health and Safety Code. A voluntary patient can be made involuntary if the patient refuses to consent to treatment recommended by the physician. It's that simple. It's written into law. That's all it takes to switch you over. And so this is just a quick review of the slide I showed earlier today. So wellness checks are a really common way that this kind of coercion is bleeding into our communities, where all sorts of different people, a lot of the providers you're interacting with, the helplines you might call, other people you're interacting with may at any time kind of call 911 and get you incarcerated in some way. Then there's a couple studies, big shout out to the disability rights organizations. We heard about both Jonda and Disability Rights Ohio today in their work, and I drew on their kind of systemic investigations of psychiatric hospitals and psychiatric care quite a lot for my book. It's very, very useful, and we don't have anything like that in Canada. That you've got these federally funded organizations that do systemic investigations, and it's terrifically helpful. And really, it's quite shocking when you look from state to state how dangerous the situations are. So here's Disability Rights Oregon, where they looked at this whole issue of wellness checks too. And in 1 year, more Portlandians were arrested than the federal homelessness count found. often calls from diverse groups and organizations and people. And, their homelessness itself appeared to be the driving factor. Essentially, they were getting charged with disorderly conduct and trespassing and things like that were really associated with homelessness. And a very similar study just in Washington, also recent, and there's overlaps between these two studies, so I mentioned the other one as well. But here were the staff at the hospitals themselves making calls to 911 or directly to the police to get people moved. So essentially, as the last quote shows, jail commanders reported tension with their local hospital over a high need population that neither system is eager to serve. So people are just being bounced back and forth. So the hospital are kind of, oh, you're in the waiting room. We don't really want to treat you. We don't think we can help you. We know you already. We're going to try to get rid of you. We're going to charge you with trespassing if you don't leave. And then a lot of people were charged with trespassing. That's literally the most common thing. So people are seeking help at hospitals and being kicked out and thrown into jail. When I look at those numbers too, I couldn't help but extrapolate it nationally. And this phenomenon alone might account for a very significant proportion, or indeed all, of the imprisoned population of mentally ill people. Like if you add I know, a very rudimentary study here. Don't quote me on it too extensively, but I think it's worth looking into, right? Because it was hundreds of calls annually from just, I think it was 6 hospitals in one jurisdiction. Getting people locked up in jails who were mentally ill and seeking assistance. And there's a longer quote that I took from them around that issue, saying, it's often said that people are ending up in the jail system because they're not being treated. Well, here they are seeking treatment and not getting it. So another example is social workers and mobile crisis teams. There's 650,000 social workers in the US and working in all these different areas. And their training and licensing requires mandated reporting often, and it's a gray area really what's required there, but it's often used to contact 911 and get people incarcerated depending on what they say in different situations, whether it's talking about having violent feelings or feeling suicidal, and depending on the particular social worker or the particular tendency of their licensing body, they may feel greater pressure themselves to lock people up. And then you have this is really interesting. This is a social work professor, Maria Leggio, who I interviewed, but she talked about the sort of collateral damage, and it's also this general training of the public that's going on, where we're trained to spot the signs and symptoms and report people and contact 911. And she herself, her mother, had a rather sort of, in her own way, a kind of serious mental disorder of sorts, where she would wander a lot and kind of see things that other people didn't see, and that sort of condition. But she said, emphasized repeatedly too, my mother was never in any way dangerous. I was never afraid of her. My father taught us that she was just really different and kind of magical and special and quirky, and we loved her and we wanted to care for her. But at one point it was just too much, sort of her wandering. She'd sometimes wander off and they would worry. And they got involved with the mental health system. And she was quite young still, like 6 or 7 at the time. And right away she was conscripted and trained by the mental health system. And so she was told that, her mother wasn't magical, but really sick and disturbed. So as a 7, 8-year-old, she's being told this by mental health professionals. She was trained to constantly monitor and report her mother's activities to them. Often she'd be in the room. They would interview her mother. How are you feeling? What are you doing? And then they'd turn to these kids who are 7, 8, 9 and say, yeah, is that true? Can your mother be relied upon? So constantly undermining the mother in the family situation. They were instructed literally to threaten their own mother to make sure she kept taking her medications. And these kinds of training programs, if you look at them, I don't know if you ever looked at youth mental health first aid, they're often really teaching this kind of behavior quite explicitly. And so I think it's just really important that we all kind of highlight that even the training programs, they're supposed to be ostensibly training you to help de-escalate a situation. Often within them, they're very medicalized. One of them, the mental health first aid, puts 3 little happy faces beside electroshock treatment treatment and antidepressants as part of an advisory for, how you can help somebody is get them into treatment right away. So you're often told to call 911 if you have any concerns, and really direct people to professional help. And so this is another one. So there's certain states where AOTs, although it's on the books, it's barely implemented at all. Assisted outpatient treatment where you're forcibly court-ordered drugging. And nevertheless, assertive community treatment, which is supposed to be voluntary, there's a lot of overlap now between these things. A lot of times the ACT teams will actually implement an AOT. And even when they're not, I'll show you some surveys here. So there's all these group homes, supportive housing where ACT teams might be involved. And here's some sort of amalgamation of a number of surveys I saw that were done of ACT team members themselves. So 90% frequently or always delivered medications, 85% made sure the client swallowed, 71% firmly directed consumer to take medications, 40% threatened to hospitalize if no medication is taken, and 32% involuntarily committed the consumer. So those are pretty high rates. And effectively, I'd say that looks like an average voluntary assertive community treatment support system has been converted essentially into a court-ordered program. This is another really interesting study. John Monahan led this one about leverage. Across 5 US cities, more than 50% of people accessing, quote, voluntary outpatient services reporting having experienced threats to remain treatment compliant. So most often the person's housing or social security income was used as leverage over them to induce compliance. And this is one of the reasons that the PAMI, the protection and advocacy organizations and disability rights organizations, have been given federal authority now to investigate social security income situations, because there were so many complaints about that thing being used as leverage inappropriately, or people being exploited, because Social Security has its own criteria where someone else can take charge of your Social Security over you and then use it as leverage to induce different types of behavior. And then this is a really interesting one I just looked at recently, and it's suggestive rather than definitive, but in California, so the AOT rates are very low. There's been really consistent political resistance to AOT there. But 70,000 people, 30,000 children, I think it was 40,000 adults, are in what's called full service programs. So that's 24/7 sort of ability to call, contact, bring somebody in, either you yourself or the people who are overseeing you. Assertive community treatment teams are often part of it. That's obviously many more times people that are in inpatient care at any time. These are mostly congregate residential settings. And here was the number that sort of blew my mind, was this independent study had specifically looked at, are they using housing first policies or not? And what they found is 70% of these programs required treatment compliance, and that was usually connected to the housing. So essentially, you're going to comply with your treatment program, or you're not going to get your housing anymore. We're going to kick you out. So to me, again, I just go, that looks to me like we got 70,000 other involuntary patients in California. I'm at this point, they didn't come out and say that themselves in the study. I don't know if other people would see it the same way, but to me, talking with people that work in these programs, they often describe it that way. So I'm not surprised that this independent study found it. So that's basically my little presentation on that. And I think it's just important to kind of put that data together with Jonda's story. I don't know if you have any thoughts you want to offer, Jonda, on how they interrelate, because to me, I think it's important. It kind of portrays this rather dark and difficult and challenging and dangerous sort of system that's out there in our communities right now. And it's really underreported, under-discussed, and unclear and unregulated. It's very, very unregulated.
I just want to do a quick ad here for a second for Rob's book. If you haven't read it yet, I really encourage you to take advantage of Ashland's ability to give it to you at a lower price than Amazon can even. So when I was reading it, I'll tell you, I had to put it down quite a lot. It was just too much to take in all at once. I think I've seen a lot in my personal and professional life over the many years that I've had. But some of the stories in there that Rob was able to share really brought some things to mind as far as how bad it is in our system and how bad it's broken. And all of you as advocates, I hope that if you take one thing out of today, is a call for advocacy to see what you can do to change the system so that Rob can't get the kind of stories he's been getting anymore.
Thank you. Yes, I'd love to be put out of work on this issue. Yeah, sure, of course. Well,
Ashley, any questions online?
No questions yet. If you have any questions though, you can add them to the Q&A on Zoom.
Oh, we've got questions in the room. I'll try to do your best to be as loud as you can when you ask your questions, so the folks are struggling online to hear the questions. Mr. Stone, I know you have a powerful voice.
I try. Thank you both for the presentation. Thank you so much for sharing your story. It's really helpful to get that first person account in real lifetime, and I know it takes a lot of courage to do that. So we want to take that.
Yeah, let me affirm that too. I mean, you just gave me an endorsement for my book, but man, I got to thank people like you who are willing to stand up and tell these stories, because I know, in many ways it can be hard. But I hope it empowers you in some way, and because it's so important. Like, my work can't exist without people like Jonda, whether sometimes they speak anonymously, and that's okay too, but the people that are willing to really stand up there, this is my name, this is my story, this is my journey from beginning to end, it really helps people understand and contextualize all of this, and it's totally what drives me too. So yeah, didn't want to interrupt you, but I wanted to affirm what you're saying, and yeah, thank Jonda and everyone that speaks out.
Absolutely. So my question really is to both of you, but it was came to my mind as you were talking about the drug holiday, the medication holiday, and how you completely fell apart after that. And it made me think of sort of a more commonly discussed issue, which is compliance problems with medication, right? And we know sometimes people don't want to take their medication because they don't like the way it makes them feel, or prevent side effects, or whatever. And so then people will stop taking their medication. And when they stop taking medication abruptly, very often it's not so much the reemergence of symptoms of an illness as it is the withdrawal response to the medication being stopped so quickly. But we misinterpret that many times to say, oops, see, the medication was really helping you, so you should get back on to that. I'm wondering if because that then feeds into this whole coercion thing, right, involuntary, so I'm just wondering if either of you have some thoughts or comments about that, and what we can do to be a little more thoughtful and responsible about medication management. Some of the issues that we're in.
Do you want to go first?
Yeah, I'll just go. I think Jonda highlighted one of the things that even too, at a certain point, it become very difficult for the person themselves to know for sure, hey, is this drug helping me or not? So I think ultimately it needs to be that person's decision, because no one knows better ultimately, than Jonda if the medications are helping Jonda, right? She can certainly ask for people's feedback on how do you see me, and take that into consideration. But I see this issue and this problem is widespread now, that if you're on them and you're doing relatively okay, it's used as explanation and justification to keep forcing somebody. And conversely, if you're not doing well on them, that's used as justification to keep you on them and maybe even increase the dosages. It's strange. It's just like it does not come into debate and discussion within the mainstream. It seems you're stepping into the more radical framework all of a sudden. sudden, as soon as you just raise the question of, hey, maybe these drugs are not helping, and especially if the person's saying they're not helping me and I really want off of them. And, and I do interview psychiatrists and psychiatric residents in the book who say that they're specifically trained in that way they aren't trained to look as, oh, perhaps the person's psychiatric systems are being caused by a medication. Perhaps a reduction in the medication might actually help. They're always told to constantly see that as, oh, that's a stronger version of the illness and needs to be more aggressively treated. So they add new medications and more stronger doses. So they're specifically trained in that way. Clearly that needs to stop too.
Just my 2 cents worth here. I did take into consideration stuff when I had the drug holiday, and I was really reacting poorly afterwards, whether or not it was withdrawal symptoms or not. And I did wait longer than what the half-life was of the medications and stuff to let them clear my system before I finally made the decision that yes, I was better off with them than without them.
John, I want to thank you also, like everybody else, for sharing something that just shows how vulnerability is such a strength. That was really impressive. Thank you.
Thank you.
I also want to say, in light of Pat Risser, who is one of the biggest reasons why we're here, he would be very pleased with the fact that you had the strength to share that, because his biggest phrase, what I always heard, was nothing about us without us. And so thank you again for reinforcing that. So in light of, I have the opportunity to speak to the group next, and I want to clarify something because I want to bring it up if this were so, but did you say that a good part of your depression started from a medical issue that you were struggling with and it took the time? Did I understand it correctly?
Yeah, I had about 4 medical things go wrong all at once. And just the gist of that caused me to wonder what was going on. And the sadness started kicking in, and all the rest of the feelings and stuff around the depression, the worthlessness, the helplessness, the inability to think, the racing thoughts, you name it.
So I appreciate that, because I do inpatient medicine. And so I think for everybody in the room, this will be a nice segue into our next session, because it's about us being aware of the fact that medical issues prompt a lot of these emotional responses.
Yeah, and I cite a couple studies in my book, like big ones from the American Emergency Physicians. The American Association of Emergency Physicians did a sort of systemic kind of review, or narrative review of sorts of all the studies on that, and found huge percentages of people that are presenting in emergency rooms with psychiatric symptoms have readily diagnosable medical issues that are either causing or exacerbating those symptoms, and they're routinely misdiagnosed. So it's a big, big issue.
I want to thank both of you as well, and your courage is just, it really touched my heart.
Thank you.
My question is, because you talked about the advanced directives for psychiatry, how responsive are facilities to that?
I have not had to test it at a psychiatric hospital since I've been out, but it did lead to a really good discussion with my psychiatrist. And we were able to discuss exactly what I wanted when I wanted it. And he now has those guidelines to know when I say I'm bad, it's bad, and I'm searching help right now. Or I'm so bad that I don't recognize it anymore. Does that answer?
Yeah, I just wondered if people came to a facility with that document.
I know.
Would they be honored, or would they be treated? They had that, and it's taken as a.
I actually started mine when I was at Appalachian Behavioral Health. So they teach it there as one of their groups.
Yeah, and I don't know what the legislation is in Ohio. Is there legislation that authorizes them? Yeah, okay, so that's cool. Not a lot of states specifically illegalize them essentially for psychiatric patients. or ignore them. And there's been a couple interesting studies I cite in my book where they looked at, I think it was Virginia, shortly after they had basically passed legislation say, yes, we want these, we want more of these, we want patients to do them. And they I did about a 5-year review as to what had happened. And they found not a lot had happened as a result. There was a lot of resistance within the system. There was some clarity. People would maybe write up an advance directive and then the institution go, well, we can't offer you therapy of some other kind because we don't do other kinds of therapy, things like that. So yeah, I think it'd be great if everybody could do these things and they would be enforceable, but we're not there yet. But definitely it's a great opportunity.
All through both your presentation last night in the library and then I keep thinking, wasn't there a movie made about this with Nurse Ratched and things? And we were all so horrified and wanted things to change. And then all this is forgotten and gone away. If I weren't on the Mental Health and Recovery Board, I would have no idea that this was going on. I'm very fortunate that this has never occurred to me or anyone in my family, but we're all the ones that need to make change in the world. As you know, only half tongue in cheek when I'm saying you need to find a producer and do another movie that everybody goes to see and realizes that this is going on. How do the rest of us, like me, who would just be a regular part of the population, blissfully ignorant of this, how are you going to reach all the rest of us and get us all worked up so that this becomes public knowledge? Until it becomes public knowledge, it's not going to change.
Yeah, well, it's interesting, I'll say in the efforts to publicize the book and get some attention to these issues, I can, without disclosing names, I'll just say a lot of very prominent journalists from very prominent publications in this country expressed interest in seeing the book. So far, no coverage at that scale, but it would be nice because one of the things is, as I highlighted earlier, it contradicts a big mainstream narrative that's out there. So in some sense, it would require that publication to kind of go, maybe we've been presenting some key elements of this incorrectly. Even now, as the whole homelessness, we've got to round them all up and forcibly drug them issue is playing out in some of the biggest centers in the country, New York and California, who largely define sort of what's happening in these issues. So yeah, it's hard. One Flew Over the Cuckoo's Nest is amazing, but if you reread that book, it's incredible how accurate it is to what's going on still today. That book was just an amazing piece of writing in and of itself to inspire that movie. So they're not easy to just pull one out of a hat. If I could write a One Flew Over the Cuckoo's Nest and get that out there, I would do it in a minute. But yeah. Yeah, well, there's at least 10. There are some good movies out there circulating on pieces of the puzzle. I heard there's one about guardianships. I haven't seen it. That's supposed to be pretty good. I think We Care a Lot, I think it was called, something like that. So there are some, but they, One Flew Over the Cuckoo's Nest is a pretty phenomenal thing. And then you get Jack Nicholson in the lead role for the movie. And, but interestingly, I have to point out, the American Psychiatric Association has gotten tons of traction with the fact that the movie version, showed him being electroshocked while he was awake, which is generally not done. It was clearly done as punishment. And Ken Kesey, the author of the novels, really didn't want them to do that. And he was presciently correct in that the APA is forever after trafficked in that. You cannot read an article about electroshock today, literally almost, without One Flew Over the Cuckoo's Nest being referenced as, it's not like that anymore, even though even then it wasn't done that way, right? So even that kind of stuff can backfire on you if it's not done well and appropriately. So yeah, but I agree, we need it more public.
I don't have a question, but I wanted to speak a minute for the medical side. I'm a mental health nurse practitioner of the medications. And for 5 years, I worked in a long-term care facility, and I was in charge of keeping track of psychotropics and trying to get the lowest effective doses for our patients and trying to make sure that they were not being overly medicated And while I was doing that, we earned an award from the state and from federal that we had the lowest amount of antipsychotic uses in older adults in the state and federal wide. So it was kind of a nice thing, but also while I was doing it, I found that there were some people that when you have to make those changes per Medicare or Medicaid requirements called FTAGs, then even if you minimized it down to like even a half of a dose, a person would spiral out of control. And then I would have to get them direct admitted to a hospital because of problems with going to ERs and things like that. And also I had patients where I would try to make sure that I was trying to get to the lowest effective dose. And for like 6 months or more, they would be off of the medication. And we start seeing, oh, they're having all these different things going on that, started to slowly, progressively get worse over time. And then we were like, oh, wow, we look back because I have to document everything and make all lists and tracking and all kinds of things. And we're like, oh, well, they had this medication reduced. And then when we put them back on medication, then they started to improve. So it's not an easy answer. And it requires all the disciplines to completely and totally work together to advocate for their people and for their patients. And sometimes it's sad to say, but there's just some people that are in positions that aren't meant to work in mental health. And so there's a lot of problems and complications that go along in those areas, and it's sad. And thank you for your story.
Thank you.
I appreciate it.
Well, thank you for the wonderful work that you're doing in community behavioral health, because that's a really needed service.
Maybe time for one more and then Ashley has one.
I'll just quickly comment on that too, that we clearly need more study and more support for your safe tapering off of these drugs, because it can take years, especially if someone's been on them for years already, to safely do that. And there can be rebound effects even months after you've been fully off of these drugs. So there's a lot of issues there too.
Hello, my name is Rachel, and I actually have experienced both sides of the spectrum. I had been hospitalized, suicidal, but I also had a manic episode and was arrested and put in jail. And of course, I was suicide at the same time. Of course, I was stripped and I got some kind of Velcro type outfit. The Velcro didn't stick, not even a mat, not even a toilet. There's a hole in the floor with a rubber on the wall, and that's all it was allowed to have. And officers got to come and see me every 15 minutes through a little glass window. The whole time I was there, I did not see one medical professional of any type to help me through it. The only way I got out of it was to tell them I wasn't suicidal anymore. So then I went home and I went to my doctor. But the whole time I was there at that time, I didn't see a counselor, I didn't see a nurse, I didn't see anybody. So I've seen both spectrums, being in the hospital and then getting medication that actually was mixed with stuff I was already on, which nearly killed me when I got out. And then the opposite, where I got no treatment. So, and I noticed a lot of people hasn't touched on that side, but there's also that spectrum. Instead of going overload, there's also the part where they don't recognize it or want to ignore it and not treat you at all.
Mm-hmm. Oh yeah, absolutely. That's not uncommon that people end up in that kind of have that kind of experience in an inpatient unit.
All right, Ashley, do you have one before we break?
Yes, actually, one just came in. I know there is a lot of concern about the system's approach. Are there approaches to aid recovery that presenters can recommend?
What was the question?
Is it approaches to recovery that the presenters can recommend? Is that what you said?
Yeah, so I'll read it again. I know there is a lot of concern about the system's approach. Are there approaches to aid in recovery that the presenters can recommend?
Do you want to answer that first?
Go ahead.
Yeah. Well, I mean, I recommend, I think a lot of things that are sort of implicit within Jonda's story and many people's stories is often it's connection with others, genuine friendships, supportive people who are really trying to help you with your own agency and empowerment within the system or outside the system. That all that kind of stuff seems to really help people. Problem solving, just situations like, okay, what's happening for you now? What would help you now? Is there anything I can do? Is there something someone else could do that would actually help you in this situation in a realistic way? Because often there are factors. It's not just, sometimes it is just floating, up there in our heads, what's happening. But a lot of times it's rooted also in something practical. It's happening in our day that, well, also, I don't have rent money this month, or also there's something really stressful going on, in my life in some way that's making that crisis more severe, and that can be dealt with. So it might not solve all of your problems, but it can make a real difference.
I'm a big supporter of peer supporters, and I just want to give a big hand to those of you who are. I know we've also got a couple of trainers in the room, and thank them for doing all that they do to help you guys with what you need to do. I think that's a big way to deal with individuals, so that you're getting somebody that's knowledgeable about what you've been through, or at least similar issues, and being able to support one another. And that's just a beautiful thing.
All right, we are our final 5-minute break before we have some.
Thank you. That was awesome.
Thank you, Rob.